what this session is. Hi. Hello, everyone. How are you going?
Hello,
Good to see you
everyone.
all. Good to see you all. So welcome. Welcome all to the AMC MCQ course promo session. And thank you in particular, Simra, Laura, and Zainab to help me conducting all this session. Can I just ask all of you, because we've got participants joining in from, I think, different parts of the world, if you just keep on adding them, that'll just make sure that this session is run seamlessly.
I'm
Um,
doing good.
okay, perfect. Thank you, Simra. And thank you, Laura, for adding, and thank you, Zainab. So we got Valeria, we got Rima, we got Gule Zehra, Baloa, Hafsa, Saroj, Neelu, and someone's just joined in now. So you've got people coming in. Excellent. So any sort of insights before we start? Or shall we just give it a go? I think we should start because we've got quite a lot of ground to cover. We should start in the interest of the time, and people can always check up on the live session later after.
Right. Yes, fantastic.
Dr. Rizwan is unmute. Mute.
Unmute. Excellent. Can you hear me? These are the perks of the live session, right? All right.
Yeah.
So in today's session, what we're going to talk about, there's a few things that I'd like to talk about in particular. So I'm going to talk about why AMC is important. All right. That's something which is very crucial to know, because there are a few things which make this exam quite unique as opposed to other licensing exams like PLAB or USMLE or Canadian exam or Middle Eastern licensing exams. And we're going to talk about some of those highlights then. Then why should you do emergency focus AMC course? What's something which makes us unique? Obviously, I can tell you a dozen things, but I think there should all be evidence and quality based. And I'll touch base with the team as to why we are so important that you invest your time and energy with us. And how do you get started? Look, one of the most frequent questions that I get is how to register for a course. What is your website name? What's your email address? And no matter how many times I go and describe that, there's always there's always more and more questions surrounding that. So I'll cover some of the registration aspect as well. Okay. Now the other thing I'm going to cover is, or not me, is Dr. Laura is going to cover about preparation, resources, and strategy. So thank you, Laura. I think you've got a few things to say. And emergency focus AMC 1 course, that's where I come in back again, and I'll show you some of the registration pathways and how to register for the course if you're interested, and how to access the portal. So we'll talk about that. And then we'll do some practice MCQs. And Dr. Zainab and Dr. Laura are going to share some of the slides that they've made. And finally, what we're going to do is portal and registration link again. Now, Dr. Simra is going to be helping me out because there are some things about the jobs. And Dr. Simra, you have got some unique insight about AMC 1 and job prospects. So you'll be sharing some of those in terms of discussion, in terms of if there are any questions from the participants, then you'll be helping me out with that because you are much more aware and much more in tune with that. Is that okay? Perfect, perfect. All right, excellent. Moving on. And yes, of course, if you've got any questions, then please ask them at the end. But more than happy for you to interrupt. You can use the chat box here, or I don't know if it's going on the Facebook Live, you can use the chat box over there in terms of Facebook Live. So without further ado, why AMC 1? So Australian Medical Council exam is very simple and clinically oriented. If you go and visit the website, they basically say that this exam is pitched at final year medical student. And that's absolutely right. The subjects, the clinical details, the scenarios, they're all based on the final year subjects like general medicine, general surgery, pediatrics.
Dr. Rizwan, you have to unmute yourself.
you are entering someone into the session and you're muting. Don't mute them because it mutes me as well. So
Yeah.
can you hear me now?
Yes.
Excellent, excellent. So where was I? So I'm saying that this is a clinically oriented exam, which is based on final year subject like general medicine, general surgery, pediatrics, obs and gynae, mental health, and also some public health questions. So it is very basic exam, which is, so if you've done your final year very well, then obviously you will do well in this exam as well. There are no basic sciences. All right. So that's very important. No anatomy, pathology, physiology, pharmacology. So all those subjects are done and dusted. However, there would be components in a clinical setting about those exams. You have to have a basic understanding, obviously. Now, that's the only exam that gets you right into the job. And we've got Dr. Simra, Dr. Laura, who have passed AMC1 and they've got job offers and they're working as well. And Dr. Simra is the one who has got unique insights after AMC1 and which of the hospitals, how the application process should be like for someone who's passed the AMC1 and what hospitals are more IMG friendly from that perspective. We'll get Dr. Simra to share some of that insights a little bit later, and then we'll touch base on that. Then I'll talk about, the WBA program, because some of these, that might be the only exam for some of the participants to do. You do AMC 1 exam and you may never have to do AMC 2 exam. Although I'd like you to do AMC 2 exam because this is an exam which leads to a full registration, but there's some other pathways like WBA. And Dr. Simra, I think, wants to say something, is it?
No. I'm just like, I can say about WBA later. I'm doing it.
Okay, all right, okay, excellent. And look, this is one of the entry pathways to the Australian health system. As I said, it is one of the unique exams which lets you enter into the Australian system. Just by doing AMC1, you can apply for general training, medical officer rotation. You can apply for emergency medicine, RMO jobs. That's how most of the IMGs get into the system. And after that, you can either do clinical or you can either get onto the WBA program, leading to a full registration, by which ticket you can enter into multiple training program pathways, which is basic physicians training, emergency training, critical care training, psychiatric training, GP training pathways as well. And plus, if you're not fully registered, even as a limited registrant, you can enter into the GP, pesky pathway by GP exam. So this exam has got a lot of, I'd say, credibility when it just on a rights of very simple content that it's testing. It can get you a lot of oomph for your time investment and for your money for that matter. And obviously, Australia in the next 12 months or over the next 12 months is facing some serious doctor shortages. We all know about that. There is deficiency of doctors for multiple reasons. One of the main reasons is that the current workforce, which is in the system, is no longer part of the workforce in the same number as they were about 12 or 24 months ago because of COVID. People are burnt out. They've made a career switch. They've gone part-time. Some of them have taken some other jobs. So it's all led to a different dynamics in the workforce. Number two reason is that the medical students have had the curriculum delayed. So they are not joining as early as they were. So that obviously also adding to the staffing shortages. Number three, there's a huge demand because there's a huge backlog of patients. So the patients who've been waiting to get into the medical health system, to get their elective surgeries done, to have their elective procedures done, to have their other issues sorted out, they've been on the break. And now all the floodgates are open and there's not enough staffing resources to meet that demand. So what are we seeing right now? We're seeing tremendous amount of recruitment drives across, all of the states. And there are people who've been invited from, overseas to attend to the interview. There are people who are invited from, local who have passed their AMC2. In fact, such is the deficiency that the people who've had almost 10 years worth of gap have been able to get their first job in the last 12 months or so. And I think this trend is going to continue uh, to head in this direction for over the next 12 to 18 months. So this is a time of opportunity. And this is the single most uncompromisable step, AMC1. You must have done this step to reap the benefits of getting into the workforce. And I think almost similarly, when I was in the UK, there was a point in time in 2000 when there was a lot of staffing shortages for different reasons, but there were staffing shortages. And there's a huge number of IMGs who were flocking into UK system. By the time I got entry into the UK system in 2003, 2004, which was 3 years afterwards, the system was already at the saturation and breaking point. So what it meant for an IMG like me, that when it came to the training positions, I was not getting the desired training positions. So hence I had to move into Australia. So that's the kind of similar dynamics. I think Australia sort of loosely follows the UK system in many ways. All right. Any question from that point of view? I think we are all good. This is just a very basic understanding. And then, yes, this is often the first step to the permanent residency in Australia. So after AMC1, you get limited registration, you work for 12 months under a WBA category, you pass AMC clinical, and you can apply for a permanent residency. Obviously, we're not covering the immigration side of things because we're not migrant agents. Laura, do you work as a migrant agent part-time?
No, I
All right.
wish, but I'm not.
All right.
I'm
Okay.
working for emergency focus as a migratory agent. So many messages.
All right. Okay. So we will utilize Dr. Simra's migrant expertise in that, right? Because obviously she has got unique insight. I came here on visa. Simra came here on visa. So I think we make all share some insights from that point of view. Good. Good. Now, why through an emergency focus? Why should you even consider coming to us? What is the unique perspective that we offer? So look, one of the things that we have been doing is that we've been doing face-to-face courses, and these are some of the pictures that we did last course in terms of doing the cannulation workshop at Liverpool Hospital as emergency focus course. Both Laura and Simra may remember because you've all been a part of those courses. And yeah, and then we did one at Wollongong recently with face-to-face clinical procedural skills course. We've been doing clinical orientation course. In fact, this is one of the completely new courses that we introduced in the view and face of COVID restriction, because there were not many medical clinical observation positions, and we thought, okay, fine, there's a huge need and demand for these IMGs to come and face, learn about the system. So this is a proper bridging course. I don't know why somebody would call their course as a bridging course when they're not really drawing any parallels of understanding to the local health system, but we are doing that because we are learning in system. We also had our AMC clinical course been ongoing for a while, and I don't know, I've lost count how many AMC clinical courses we've conducted. Essentially, we've been running AMC clinical course since April last year. So yeah, so I think, and we run 2 sessions, morning and evening. So about 10 or 12, and we currently booked out till February. So current clinical course is booked out. So what is the missing puzzle here? Can anybody tell me? We're doing all this hard work.
MC1, the beginning one, the first one.
That's right. So this is the missing piece of the puzzle. It's almost like a jigsaw. And I've been getting various inquiries that, look, you've been doing a lot of work and we need to start to have a basic idea how to get into the Australian system, how to prepare with the AMC MCQ course. And there's not much information out there. And the current courses right now, they seem to lack the quality. They seem to don't meet the expectation of improving the understanding. So look, whenever you do course, there are 2 understandings behind that. First of all, you're there to pass the exam. And at the same time, I also think that we've got a bigger responsibility of making you understand about the system. And that's why our courses are unique, because when you do our courses, our faculty and tutors are the ones who are working the system. Number one. So they've got direct understanding of how the system works. So when they're teaching you something, it's not just based on theoretical knowledge of passing the exam. Obviously, they have passed the exam, so they've got that already. But there's an additional advantage of actually working in the system, which makes a huge difference. So that's a unique perspective that we offers. Um, we've been having a discussion about, look, there's seldom in fact, there's a huge misunderstanding when it comes to courses because the quality seems to taper off. And we have taken this very deliberate approach of making sure that our courses stay to the quality. So you'll never find our workshops and courses which are like a completely oversubscribed. We have got a certain number of participants. We do that and we stop the number because we believe in that smaller numbers provide better tutor to participant ratio and better live interactive session in terms of learning. So we've got a very boutique kind of course that as if we're trying to interact almost on one-on-one basis. So this is the ethos behind all of our courses, be it in person, be it online, be it procedural skills workshop. This is all which is going on in the background. And I think these courses have been making a difference. And if I have actually lost count, we've done about 12 face-to-face courses in just last 12, 18 months, 35 online workshops and courses. That IMG Medical Careers Guidance Workshop, they've got current active subscription rate of 325 as of this morning. So that's something, where you get to learn about how to make your CVs, how to make your application form responses more, acceptable for the recruiters, and how to even approach for an interview session. Plus it gets built up with other things. And we got IMGs from everywhere, not just from Australia and New Zealand. It's from Pakistan, Bangladesh, India, Sri Lanka, Middle East. I've done some one-on-one sessions with some participants coming from Qatar, Philippines, Hong Kong, Malaysia, Singapore, UK, US. There was someone who attended our professional medical documentation workshop. And there was, in fact, it was interesting. There was one participant who was trying to get to register for a workshop from Russia, and his credit card was not getting authorized. Can you imagine that? He was saying that, look, Dr. Rizwan, what can I do? I'm in Russia, but all of because of the recent trade restrictions, our credit card are not allowed to. They're not able to do the banking transactions. They're not able to do the credit card payments. But anyway, he somehow managed to talk to some of his friends in the Europe and managed to get access to the workshop. So that's good. So obviously there's been a lot of efforts going. It's not me only. Obviously it's a huge team effort, and that's what we believe in. It's not a one-man show, and that's what is the other thing which makes us distinctive from the other courses. We're not just one person doing, reading the book and running over the slides for 6 months. Okay, we're people who have got variety, who've got every tutor with a certain angle, with something unique to offer to every one of the participants. So there's plenty of good things in there. And this is all your feedback. I think whatever are we doing, it works. So the people, and honestly, I've not even put like 5% of feedbacks here because I cannot fit any of this into the screen. But people have been getting jobs, they've been passing their exams, and they've been getting to where they want to be. And we've been just a very small component or part of their journey, which I think is it's a huge honor to be able to help you. And yes, I just feel that this is something which we've taken very seriously in terms of quality. We've taken it very seriously in terms of feedback. So we're always very truthful and honest. Whenever we conclude our workshop, we ask for the real feedback. We don't bloat our feedbacks that, look, you are this and that. I tend to disregard those feedbacks, which are very, glorious and tend to glorify you and your content. Give me the real feedback. How can I improve? And that's really helped us improve our content. So it works, and it works twice. Okay, so if I was to give you a roadmap, so no matter how many times I talk about it, there's always seems to be a little bit of more appetite for this kind of content. And that appetite seems to be coming from, where do we start? How do we start? And how do we progress? And how do we get to this point? So what I have come up with is a very generic thing that you must obviously have passed your MBBS. You should also complete your internship and do it good. Why? Because AMC 1 is a clinically oriented exam, meaning whatever you see in the wards, whatever you do in the theaters, whatever you see in your clinics, and discuss your cases in terms of history, examination, investigation, the practical aspects of it will be a part of your exam. And then you should also do 12 months of RMO experience. And this is what I've been highlighting. Look, exams are only basic, in fact, essential requirement to get you to the job. There seems to be a misconception that exams get you a job. Please make no misunderstanding about that. It's not the exams which get you a job. It's two things. It's your previous clinical experience plus how you present yourself to get that job in terms of your CV, application form responses, and finally the interview. So 12 months of RMO experience, mostly in the specialties. If you're talking about Australia, it is very specific that you need to have an experience in, um, emergency medicine, pediatrics, acute medicine, and ICU, if anything. These acute specialties restore the trust of the employer that this is a doctor who's work in crisis situation and can deal with the acute problems here in the ward setting, here in an emergency setting, or any setting that we hire them. They need that reassurance. So I want to change that mindset from IMGs that look, please, if you're early in your career, do look for the job. It does not really matter which hospital you do the jobs. Honestly, it does not. As long as they are in emergency medicine, pediatrics, ICU, anesthesia, obs and gynae even, because they tend to reflect the same career progression pathway of local IMGs. So the local IMGs will do a 12 months of internship, and their RMO ship, which would be for 2 years, would be diversified in emergency pediatrics, obs and gynae, surgical specialties, so that at the end of the 2 year, they are in that, they've had that diverse experience to make a very conscious decision what they want to do in terms of their advanced training. Do they want to go into surgical stream, medical stream, pediatric stream, critical care stream, whatever they want to do. So do invest in that time. And once you're doing that, please take your MCQ because it is a simple exam. So anything which is going on in here and here is automatically going to improve your understanding of the MCQ exam. When I was doing the exam, I did the MCQ exam. I was actually working in emergency medicine, and it took me, people often joke about it, it took me 3 weeks to prepare for the exam. I just went through the questions, read some of the text around the questions, and I managed to pass the exam in just 3 weeks. But obviously, I had been working in the local health system for almost 3 years. That is in the UK. But practice does not really matter where you're practicing. What matters is that you're seeing your patients dedicatedly in the way that you should be seeing them. You can then do the English test, and then finally, you should also do your AMC clinical. That's my suggestion, because AMC clinical gives you that, breaks over your linguistic barriers and gets you more of a understanding. Now, once you've done that essential stream, you may like to consider doing these courses, which I call building up your credentials. So you can come to us and do our clinical orientation course, in which we talk about how to look after the patients in hospital setting. You should also, unfortunately, there seems to be very limited understanding of how to present yourself when it comes to medical recruitment. So medical career guidance course, as we've just talked about, is an online course, and you can come to or do. I don't really care where you do any of these courses: ACLS, BLS, procedural skills, online CBD. Do them from everyone, but keep on doing that. And I think I'll get Dr. Simra to explain, because I think she will have a lot more insights about it, and before we move on to the next session. So Dr. Simra, my first question to you would be, what is your understanding about AMC1 and the jobs afterwards? Because you seems to have, done that yourself, and you've been helping lots of IMGs in that category. What is your understanding about the AMC1 and then getting into the job workforce in terms of practical experience, in terms of how easy, how difficult, and what can be done to make it better?
Hello, everyone. Thank you, Dr. Rizwan. I think AMC MCQ is the key. I have found people who are very keen to look for the jobs opportunities. They're very keen towards looking English and everything. I know Laura and I studied 3 years before in a group, and we were only talking about AMC MCQ. We never talked about jobs. We never talked about anything, because if we want to stay in Australia and if we want to proceed our career in Australia, so we have to make sure we are doing AMC MCQ. That's the very important thing. And if you are back home, so don't move to Australia without doing your internship, because these two things are the very, very important thing. And once we are done with AMC MCQ and that house job or internship back home, then we will talk about the English test, about the clinical options. And of course, like you can see me and Laura, we have done our only AMC MCQ and we are working
Mhm.
currently. So means there are very good and bright options later on, but the door only opens once we have done AMC MCQ. And that's a very important exam. People take it lightly, but it is very, very, AMC got lots of strategies. So you have to understand the strategy. And you may heard from people that they couldn't pass the exam in so many attempts, but there should be a strategy of doing this exam. If you're following the right strategy with right time, with the right guidance, I'm sure you will crack this exam in first time.
And what is your understanding about those GPs who are a bit more mature doctor who have done the internship and they're currently working or they want to get into the GP pathway in terms of pesky route after AMC?
Yeah, I think I'm checking on the questions on Facebook. One of them has posted as well the similar question that they have done their residencies in their hometown and now they're looking. Even for that, you need AMC MCQ Part 1.
Yeah.
Now, after AMC MCQ Part 1, you have to decide whether you're opting for standard pathway, just like the way I have done. You are opting for GP pathway. You are, because there are other options like pesky exams, clinical exams, specialist training pathways. But if you don't have AMC Part 1, they will not even going to look your application. So that's very important.
So that's a very important point that you've just raised in terms of a specialist pathway. So recently, can you hear me? Yep. Okay. So recently what has happened is that I've had a fully qualified emergency physician who has done his residency in Pakistan at Aga Khan University Hospital. And he's done his fellowship of College of Physicians of Surgeons of Pakistan in emergency medicine. He's finished that. He was working consistently without any career gap. Instead of doing AMC, now these are the very select group of people who have not done AMC but have managed to find jobs here, being partially recognized. So that was a bypass system, and he completed all of his emergency training requirement. He was working in one of the European countries, and when he submitted his paperwork through the Emergency Medicine College, that paperwork got accepted. He's not recognized as a consultant, so he still has to do emergency fellowship exam, but he's been given an exemption from primary emergency exam, and he does not have to do AMC exam either. So that's good from the point of view. His specialist accreditation will lead him to full AMC registration, which is a bit of a risky part, because obviously if you don't pass the fellowship exam, that's the point which I want to make very important, because fellowship exam are different kettle of fish. And if you're in that limbo that you're not able to pass the fellowship exam, right now there are about 3 attempts in terms of
Only 3 attempts, right? Yeah.
and 4 attempts at OSCE. And if you don't pass, you're out of the system. And we've
Yeah.
seen people who had to then do AMC at that point, which is not the way to go. So AMC will always come in handy. So yes, that's a very important point. Now I'll move on because we've got quite a lot to ground to cover. I'll get everybody to introduce them. You always know about me. I'm one of the consultant working in emergency medicine here, and I've been working with a brilliant set of people who tend to surround yourself with influential people, and you don't have to work too hard. So I'm surrounded by the likes of Laura and Simra and Zainab today, so I think I'm in good company. So all right, Zainab, why don't you tell us something about you, sorry.
Hi, hello everyone. I'm Dr. Zainab Sayyad. Just like Dr. Rizwan have said, he has lots to his credentials. I don't have a lot, but why I am here, because I am an IMG and I have done AMC. So currently I'm working as a resident at RDH, and the first thing that I'll be going through. So I'll just give you a basic gist of what AMC exam looks like, what are the expectations, and how to maneuver around that. And next, over to Laura.
All right.
Hello, I think we can go for Simra because of the picture. Simra is there.
Oh.
Yes. Simra, go for it.
Hello, everyone. My name is Dr. Simra. I have done my AMC MCQ, and currently I'm working in one of the hospital in Victoria, and I am currently finished my 6 months of WBA as well. So yes, and I'm here to teach you guys with all my fellow colleagues regarding MC1 and how to be working in Australian system soon.
Excellent. Excellent.
And now I think it's my turn.
Yes.
Thank you. So my name is Laura, and I am a doctor from Spain, and I've been through this pathway for a few years. So my situation was a bit difficult, but I've gotten through it, and I was able to secure 3 jobs. In which I am deciding now which one to take, which is fantastic. And I've been working in 2 private hospitals for the last year, which has given me a lot of experience. And I pretty much have done all of the path, but the clinical course that emergency focus offers. And that's why I'm here, because I passed my AMC MCQ, and with Simra, we studied together as well. So we kind of had a similar experience. So I'm here, and I'm very excited to teach you all.
Okay. So what I'll do now, I'll actually stop my slide share, and then I'll get, I think it's Dr. Zainab's turn to start next. So I'll stop my share. Dr. Zainab, you can take over from here if you like.
I think my screen is visible now.
Yes.
Okay, so just quickly going through what AMC standard pathway is, which we will be covering today. And obviously there are a couple of other options like the competent authority pathway and the specialist.
Dr. Zainab, get your mic a little bit closer. There we go.
Oh, I'm so sorry about that. Okay.
Don't worry.
Okay, so we'll go through the basics, some very basic things, but then we'll focus on AMC MCQ mostly. So what AMC standard pathway is, which we all are crazy about, but obviously there are competent special authority pathway as well, which Dr. Isvan has talked earlier. So why standard pathway? So all the international medical graduates, which means those who have not graduated from Australia or New Zealand, we need to acquire a registration prior commencing our work. What is going to unlock it for people like me? It is the standard pathway. So the standard pathway, it usually has 2 options. So obviously the first and foremost is the AMC MCQ examination. It could either be followed by the clinical exam or the WBA. Clinical exam and WBA both have their own pros and cons. So clinical is the cheaper option, and WBA is the expensive version of that, but it alleviates the pressure of you for taking another examination. So tailored according to individual practices. Okay, now the first and foremost and the commonest thing among all the pathways is the AMC MCQ examination. Some very basic things about that. So what is it actually? It is something not very fancy, as the name indicates. It is just 150 MCQs, basic choice questions, nothing multiple. Just click and collect your certificate from AMC. So it's click and collect, but it's not groceries, but AMC certificate. Okay, so how does it work? So it's just a 3.5-hour session. It's just like your entrance exam into the medical colleges we took from our home countries. It's an entrance exam into the Australian medical system. What is going to happen? You are going to book your exam first. Once you go to the center, you will see that there are certain segments everywhere. Everybody gets their own screen to work around. Okay, what is going to happen? What to expect? So we are going to get 150 type A MCQs, which implies that there would be only one correct answer and there would be 4 other options. One of them is grossly irrelevant, so we are going to rule that out ASAP. A few are distractors, and then through your adequate knowledge, you need to pick the correct answer. Sometimes it is just a big scenario. Sometimes they like to make it more, let's just say, diverse by adding some pictures, some data, biostats, some things like that. And I think everybody who has taken AMC examination, they will say that I got X number of ECGs, Y number of CT scans, I got this X-ray, blah, blah, blah. Okay, besides all the diversity, what they usually focus on is what we actually did in our final or fourth year of medical colleges, like the basic subjects, gynae-obs, medicine surgery, peds, and psychiatry / mental health, a few of biostats and epidemiology, but very few. Okay, and besides that, what are the key focus areas? So they are going to discuss about the disease progression, where they're not going to ask about etiology or pathology, but we should have some idea what is the correct investigation, management plan, and among those management plans, what is the best step, what is the initial step, which one is the most definitive. So please go through the STEM very carefully. Now, what we are expected to do in 3.5 hours while you are on the stage, you have to answer all those 150 MCQs. And once you have answered those during 3.5 hours time, you have to hit submit examination. Otherwise, it is all going to go to the drain. So you make sure you hit the submit button to get your results. Just a blueprint of how actually AMC works. So let me tell you, if you're good with medicine surgery, you are going to crack 50% of the examination. The pass point is 50%. So medicine and surgery, they cumulatively cover 50% of the examination. Then 12.5 from gynae-obs, pediatrics, mental health, population health, which are some screening services, epidemiology, biostats, and this and that. Okay, once you have taken the examination, now it's AMC's job to do the further work. You just need to pray for a result. So how they are going to calculate you for the exam, let me tell you. It's a computer adaptive test, which implies if question 1 is an easier one, you marked it correct, the next one would become a bit more difficult, or let's just say medium level of difficulty. You mark that correct, now you move to the more difficult step. But if you answer difficult questions correctly and somebody else who has answered easier questions correctly, no matter if the number of questions is same, those who have answered the difficult ones, they are going to be rewarded for that. So the scale, how this works, only the AMC people know what is the software behind running that, but we can tell you that it is a computer adaptive test. The more the answers that you mark correct, very good. The more difficult the level of difficulty is, good for you. In a nutshell, we eventually need to get only 250 out of 500, and I think we all could do that. Okay, and after 15 days time, or whenever the result is due, you will get a computer generated transcript of the results and feedback of how you performed, like in which scale you are there. You were in the top 25%, you were in the medium half, whatever. So as long as it says above 250, you are safe. Okay, and besides that, a few points that I would like to shed some light on. So remember, there is no negative marking. So please do not leave anything empty. Just pick some option randomly. Now, out of those 150, 30 are unscored. So they are not assessed. They are just the pilot questions. And you can, but the catch is we do not know which 30 are unscored. So please take all 150 questions very seriously. Now, never ever stick to something like, if I'm doing medicine, the next question should technically come from medicine. One is medicine, other is an acute obstetric emergency, and then the next one could be something from mental health. So they are going to randomly select the questions per se. Okay, good thing is there is always a clock around on your screen, so you know where you are. So please keep a good eye on the clock and use your time efficiently. Remember, all questions need to be answered, and once you click one answer, there is no chance of going back. You cannot change the answer. In the olden times, we had this thing in mind. You just click the wrong answer, flag it, so you get the easier next, but it is a great myth. Please don't fall into the trap, and correct the answer and mark the answer to the best of your capability. So this is a little bit gist of how AMC examination works and what to expect on the exam day. Okay, after that, just to give a feeling of completion, this MCQ exam is usually followed by the clinical exam, which comprises of 16 stations and 4 rest stations, which implies 20 stations in total. Among those 16, again, we do not know which 2 are just assessed but not scored, and 14 are scored. For clinical, you just need to pass 10 and you're done and dusted. But after MCQ examination, you can either opt for clinical or you may go for WBA. Dr. Simra will give you a better idea about how WBA works. Okay. After that, if you have made your mind that we need to go for AMC examination, with everything, there comes some paperwork as well. So for AMC examination, there are two things that we need to do. One is EPIC, and the other thing is to create an AMC portfolio. They usually go parallel or hand in hand. So we have to be very watchful how things are processing for us. First is EPIC account creation, electronic portfolio of international credentials. And other thing is to create an AMC account so that we can actually book the AMC examination. For the EPIC account, what do we need to do? Obviously, there is a link on the website. You go there, click on that. They will ask you for a few documents. That would be just your passport and a good size photo of yours. Besides that, obviously, the basic MBBS degree transcript. You just upload them and that's it. So if you have a look at my screen, there is establish an EPIC account pattern. Once we establish the EPIC account, you just upload the relevant documents and that's it. Now comes the most hurting part, is that you need to pay 150 USD for that. Okay, once you are done with the payment part, you will receive your EPIC account number and details in the next 2 to 3 days time. So it's a wait game for 3 days time. During this time, once we have received our EPIC ID, not verification, we are going to sign into our AMC candidate portal. Easy peasy, sign up for an AMC account, just pop in your details and you will get your AMC portfolio established in 3 to 5 days time as well. Okay, AMC portfolio established, documents uploaded in the EPIC. What's next? So they don't know if it's a genuine degree or if it's a pirated one. So they will be sending it back to your home country for verification. And during this time, they have to verify if we are the genuine person or not. So we have to book an appointment with the notary cam. The notary will just verify you that, okay, this is person XYZ. Then in presence of that person, we who have already downloaded the form, we are going to sign it there in presence of a notary. Good thing is everything is already paid off in those 130 USD, so nothing to be paid here. Okay, once that credentialing is done and dusted, now Apple will send the verification documents to your medical school, and the medical school is either going to verify them by online or they are going to do it via post, whatever is there. So good thing is that during this time, while the medical school is verifying your degree, we can book our AMC examination. But let me tell you, they are not going to release the results before the degree has been verified by the exam. So it's always a good idea to chase with your medical school and see if they have verified it for you or not, so that we can enter the system, get done with the AMC exam and see what's next on the plate, whether it is clinical or it is WBA. So that's it from my end. Now Laura will give us a bit of idea about how to prepare and how to proceed further.
Awesome. Thank you so much. That was fantastic, Zainab. It's actually a quite difficult process, and she has gone through everything very well. So I didn't have that, so that's a massive point. We didn't have that. Like Simran and I probably had no clue when we started. So this is really, really good. So I'm gonna share my screen now. Just give me a sec, and let's take it from here. So once you have gone through your EPIC verification and everything that my colleague Zainab has explained, you have to decide on prepare or not. I guess once you've done it, you pay that money, you look into your future in Australia, you really would like to start your preparation. Okay, so the AMC MCQ is, yes, it is a basic, simple exam in many ways, but funny enough, it has the highest failure rate out of all of the Western country exams for like just verification of your qualifications as a doctor. So there is something that doesn't work there, and I'm about to explain that and what's happening. So the first thing is that you've decided to take this exam. My recommendation is to get 4 to 6 months of your year and plan this 4 to 6 months for your preparation. That's the general average. There are people that are brilliant and are already working that can do it like Dr. Rizwan in 3 weeks. But there are other doctors that maybe have been out of practice for a long time and have to take months and months for preparation. But the average of doctors in general, for what we've seen, is from 4 to 6 months. And this can even be cut down if you have a proper guidance, proper support, great resources, and a great course, which, as I said, we didn't have. None of us had it. So let's say, so we got this 4 to 6 months. I'm going to plan them ahead. How am I going to do it? I want to decide that I'm going to study from 4 to 6 hours a day. And I'm always going to leave one day off at the beginning. And the recommendation for your last month will be to study more than 6 to 8 hours just to push on that last month and get everything ready. So this is an average. As I said, this is not a magic recipe that is going to get you through the exam, but it's a really good way to start. And you have to be flexible to adjust this to your needs. Very, very important thing is to find support. So one of the things is that once you decide to do this exam, make sure you tell everyone you're going to do it. You tell your friends, you tell your family, your partner, and your kids, if they can understand that mom or dad are going to prepare a very tricky exam and we need some time. So that can help you. Once you have decided, book the exam. It's very important to have a target in front of you that you can move forward to, and this will help you with your time management as well. And then I think very, very important, and I'm pretty sure Simra will agree with me on this, is that you shouldn't study alone. You should have a nice study group that will go through you in your preparation. And if you decide to join us in our course, we'll help you to have this study group and to guide you through it as well and support you. This is an example. So when we were studying, I found very, very useful Google timetable. So this is a part of your Google account if you have one, and it allows you to create a timetable for you. And this is just an example. So I decided on Monday, I'm going to study neuro. Then I'm going to practice some questions. On Tuesday, I'm going to do it again in the morning. And like that, you have a clear vision of your week in front of you. If you have classes during the weekend, just allocate your study with the same topic as your classes so you can be prepared for it. So there is a lot of plan and organization. And trust me, if you are able to do this, it's going to be way easier for you in your preparation. So as I say, Google timetable if you want to have the same timetable here. So let's go to the next slide. Very good. So let's focus on the study method. How do you approach the exam? Well, it is about your general medicine and surgery and pediatrics and gynae. It can be quite vast and you can get lost. That's one of the problems with this exam. So you have to study based on target topics and like very important, the most important topics out of all the subjects. How do you find them? Well, you have to do a lot of research online and you have to find all the topics that are coming up and create a big list and then focus your theory, finding guidelines and the books into this. Very important. I say here, you have to target your approach, but you also should study all subjects. Why am I saying this? Because this exam is an algorithm, it's a computer-based exam that will randomly choose questions for you. And maybe if you skip that biostatistics, that it happened to me in my exam, if you skip biostatistics and then suddenly you have like 3 questions of biostatistics in your exam, that can make the difference between you passing or failing. And in my case, I had like 3 and everyone was telling me, no, you're not gonna have any biostatistics, don't worry. And I got 3. So the exam works like that. So don't skip any subject, focus on all the topics from all subjects. How I would approach it, you have to, it's true that as Zaina said, the etiology, you won't be asked on it, but you definitely need to understand what you're talking about. So you do need to study a little bit to give yourself an understanding of the disease that you're gonna get tested. So I always had that part covered That's why the theory part comes into term. Then you have to focus on your investigations. And I say the same thing as Zainab: next, best, next, and best. What is this? Well, this is one of the major tricks for the AMC MCQ. They'll focus on investigations and management and treatment, and they will ask you, what is the next best step in management for this patient? Now this has been done, what do you have to do next? Do you have to do next? Things like that. So once you approach your investigations and your management, make sure you always follow the guidelines, the pathways, what's going to be done next. What's my gold standard or my diagnostic test? That's your most important test or best test. And what will be done next as the best option. I know this sounds tricky, but that is a trick of the exam. And that's why people fail so much when it's not that complicated. And that's one of the tricks. So as I said, the AMCQ approach, it's very tricky. And I say this again, it's not difficult, it's just tricky. You have to read carefully each of the questions because the sentences will change and it will change the whole meaning of the question. And you just need to pay attention to everything, every word that is in that question. You need to practice full questions. So you have to train yourself into full questions and not just recalls that you might find online, because in the exam, you won't get a recall. You're gonna have a full question there. So you can get a little bit overwhelmed if you are not ready. And once answering all of these MCQs and recalls you might find, make sure you base all your answers like on Australian guidelines or the guidelines that Australia is based on, like the British guidelines in so many instances, for example. So that is key. It's very, very important. Exam approach, do not underestimate the exam. It's very important to learn how to do those 150 questions on time. So you have to do mock tests and train your time management, very, very important. And the last thing is that do not expect to feel ready. You are never gonna feel ready, never. So you will postpone your exam, and that's a massive mistake because it's not that difficult. Once you know the tricks, once you have your time management ready and your strategy ready, go for the exam. So that is my very, very good advice there for you. Let's go with the books. I'll go through these quickly, but I just want you to have a look. You can have a look at all of these books that are very, very, very useful, and it will help you with your theory preparation as well if you want. So we have the first one is the handbook of the blue book, the handbook of multiple choice questions. This book, you should do it at least twice before your exam. First time is gonna be crazy because you're gonna be like, oh my God, I can't do this, it's terrible. But then with your preparation, you'll see how it's just gonna make sense. The Australian Medical Legal Handbook, it's a great unknown. And this guy over here will answer all your questions for ethics and legal part. It is fantastic. John Murtag's, this is like I think a bit overestimated. I didn't use it much. People do read it a lot. So it's up to you. I used it for the women's health part. That was very useful. The Anthology of Medical Conditions from the AMC, I didn't touch it, but a lot of people use it as well. Oxford Handbook of Clinical Medicine is actually quite good. It's very little, and you can go through it, and it can give you like a nice theory backup as well. And then you have all the Kaplan for lecture notes for the USMLE preparation as well. If you're not following any course that you have to study all by yourself, these kind of general medicine and surgery books will help you with your theory preparation. The same thing, these are excellent books, and lots of questions were answered with this book. The Adult Emergency Medicine textbook is based in Australia, and it's incredible. I do recommend this book so much for the entire rest of your career, to be honest, until it's updated. On call, same thing. You'll be able to answer a lot of questions because they'll give you the next, then the best next, and so on. So with this, once you'll answer. For pediatric questions, same thing, the RCH Pediatric Handbook. These books for textbook surgery, I used it. because I wanted to read a little bit more, but you can skip it if you have another surgery textbook. And then Lewley Jones' Fundamentals of Obstetrics and Gynae. It's really good for the obstetric part, and it's also the OBS book that Australia uses. For online resources, you could get ETG, Up to Date. They require quite expensive subscription. Same with Med Bullets, but they are very good, very essential. I just must say that we'll provide this in our slides, all the guidelines already there. So you won't have to get all of these subscriptions or all of these books. But for those that won't do a course, just have a look at, like, keep an eye on Life in the Fast Lane, diagnostic imaging pathways. This is essential for those pathways with investigations. Radiopedia for your training of imaging, AMBOS for extra theory, and MedBullets, as I said, and OrthoBullets for general theory as well. QBanks, everyone knows about Amedex, and if you don't know, you'll know. I recommend Amedex, is really good. It's very expensive as well, but I used a one-day subscription, and that was a bit better financially. QBank, I use it for psychiatric questions, and M+ for trial exams. So when I see these, I just see money coming out because they're all so expensive. But anyway, this is the path. All of these guidelines are very useful. Just take a look. You can take notes of them. Emergency Care Institute, RSCGP. You'll find guidelines about everything there. If you join our course, we'll provide the guidelines already for you for your pre-class preparation from all of these Australian sites, okay? And very important updated guidelines. So is this all necessary? That is a big question. Well, I thought it was. I did, that's me. The happiest day of my life. That day I received my AMC MCQ result of a pass, because you only receive a pass in green, and I was just happy. Oh God, so I put all of my, and this is not even everything, but I was able to fit all of this into this massive column. And I really thought that I needed to buy all those books, that I needed to prepare for so long, that I had to study. I got all the subscriptions and did everything, and it wasn't necessary. What happened to me, I spent 8 months preparing for my exam. I spent lots of money in books and subscriptions. That was insane. And why? What happened? Why did I do that? Because no one told me how to do it. I had no idea of how to do it. I had no guidance and no support. That's why we want to create this, because now the good thing is that, yeah, I spent a lot of money and I gained like 26 kilos there, but I became an expert. So I know how to really succeed in this exam, how to do it and how to prepare. And this is what we're trying to do together with Emergency Focus. So that's me. I hope you enjoy it. I think Dr. Rizwan will go now, yeah, to talk about the course.
Thank you,
Dr.
Laura. That was certainly very
worries.
insightful. I'll share my slides now. All right. Can you see the slideshow now?
Yes.
All right. I'll skip your parts. Thank you for that. So I think, yeah, whilst I'm skipping those slides, it's very important to understand and realize that you can clearly be very easily overwhelmed. And there's so much resources. And that's why, the online courses are thriving. The reason they're thriving, there's an information overload. And not all of that information is relevant. I believe that if you're learning something, it will be relevant at some point in your career, but right now you need to focus on passing this exam. So especially from that point of view, it's very important to stay focused. And that focus is passing the exam. So that brings it to our course. How can we maintain our focus? So very simple. We had, 3 essential ingredients which should define our course. Number one ingredient is that it should be cost effective. It should not be exorbitantly high. And I'm very sad to say some of the course provider do charge very exorbitantly from IMGs who are actually in struggling phase, and that should never be allowed. There should be some sort of standardization of these things. Obviously, you need to have a running business, but it should not exploit the IMGs. Now, there are other way of monitor like subscription based courses which are quite low in cost, but then again my certain belief is that you need to be taught by a faculty or a combination of tutors rather than one man person. And the reason I say that, like, whenever you're studying in a university, in a college, in a school, we get an exposure from wide variety of tutors, and that variety is crucial for retaining the information. Remember, you're not just trying to learn the information or the knowledge with the course, you're also trying to learn the strategy. And if you've got 4 tutors in a course, you've got 4 strategies working for you. You've got 4 experienced tutors who are improving your experience with every session. So that's crucial. We also believe that we need to have tutors who've had experience and they're working. So as I said in the beginning, that anybody could teach a course, but is that relevant teaching? Are they working in the system? That's the question one must really ask themselves. Okay. There is a very poor quality content out there. And especially if you look at recalls, you can see the quality of recalls. There's spelling mistake, there's grammatical mistake, there is the complete sense of the question is twisted. Sometimes you have trained your mind that this is a very difficult question. And when the question comes in the actual exam, it's actually very easy. And you said, oh, that question is exactly similar to what I was thinking of, but it has got certainly a lot of information. So never be reliant on recalls in the way that they are. Even if somebody is relying on recall, they've got a moral responsibility to create it in a format which is imparting knowledge rather than just making you remember that point without any conceptual learning. So any recall should have a conceptual value behind it. So high quality resources are very important. And I think what get good is a course which is not covering all the component. You need to do the trial exam from X provider, you need to do theory from Y provider, and you need to do MCQ from someone else. So invest yourself with a single partner who's going to be your study partner over the next 3 months, 4 months. Dedicate your time and strategy in that completely, and that will take you through. So that's our fundamental ethos: cost effective. We're going to be better in cost compared to most of the providers out there. Obviously, you've seen the faculty. I'll be teaching Laura, Simra, and Zainab will be the core. And whoever we end up having more on our team will be somewhere who is reflective of that sort of same credentials. And it should be a complete course. We don't want you to go through all the stack of books that Dr. Laura has done the hard yards for already. I think we don't want you to go and buy Cameron or have a subscription to UpToDate or therapeutic guidelines. When you come to our portal, which I'll show you, it will have all the information inbuilt. Lots of time is actually, and I'll use the word very cautiously, wasted in terms of gathering the information. When I was graduating as an MBBS student, and then finally when I was doing licensing exam, nearly months, like 3 or 4 months, was just busy trying to get the photocopied material, buying this book, talking to that person, just collecting the resources. And that was just a waste of time. And in this day and age of technology, we've got this valuable resources in terms of portal. So those of you who would know that, or who have used our medical career guidance course or professional medical documentation course or any of the course, I'm using a portal, which is a combination of notes and videos. So this portal is very intuitive, and everything gets uploaded to it, and you can keep that portal with you till you're preparing for exams. So you can go back and forth and reference that. Plus, the other value of our course is that you can build up your professional buddies. As Dr. Laura was saying, that you can find your buddies. as Dr. Simra and Dr. Laura were working together and studying together. So this is a very good group in teamwork. Teamwork makes it lighter. The thing that you're going to spend half an hour to learn that concept, with the teamwork, you may learn that concept within 5 minutes. Okay, so that's the other value from joining the course. Now, the other thing is that portal, our strategy is going to be based on these main things. So basically, you'll have a pre-reading session before the live session. So we will upload, say for instance, you're doing a respiratory session, we'll upload all the respiratory topics onto your portal, which you can access through your login and password. You can read those, notes, the links to the guidelines which are relevant, and prepare yourselves for the upcoming live session. So when you're doing the live session, you'll have a core concept building around that theory from the respiratory point of view, and then we'll do the MCQs. Now, those MCQs are going to be conceptual MCQs around that topic, but would also cover the recalls, because we know the value of recalls. And I'm not going to deny that, look, the recalls should be ignored altogether, but where we differ from other courses, these recalls are going to be in a high quality format. We're not going to be making spelling mistake or grammatical mistakes or paragraph mistakes. They will be done as much as to the detail to make sense for you to still use the conceptual learning, which is important. Because if you cannot apply a concept to that piece of information, what good is that recall? It's no good. It may destroy your concept altogether. So you don't want to be preparing for this material half-heartedly. So we'll use all the traces recall, we'll polish them and put it out there for you, and then we'll record our session. So if you're not able to attend your session, we'll put it up there, we'll patch it up and put it in the portal so you can go and review that session in the portal. And finally, we'll do the trial exam. The value of trial exam is pivotal in any of the licensing, fellowship, membership, or any exam. You need to test yourself. You can be absorbing a lot of content, but if you're not really improving, you're not really learning anything. So you need to constantly tell. So we'll do trial exam and we'll give you feedback, and that will also be through the portal. It will be a technology-based, computer-based trial exam. We'll get an explanation, and then each of the tutors will go through the explanations during the session classes as well, which Dr. Laura, Dr. Zainab, Dr. Simra will be able to do that. All right, okay, let me see if I have got, and yes, there's something which I've started to do recently in our AMC Clinical. I'm actually quite excited about it. We have gone through and provided students some feedback. So look, this is the area that you're working very well. This is the area where you're lacking. These are your strong points. These are your weak points. So in AMC Clinical, obviously, there's so many aspects in terms of your software, in terms of your communication, your demeanor, your frameworking. But I think same could be imparted in AMC Clinical, because once we go, initially we'll do topic wise, and then we'll go totally random. And then, your tutors will be able to give you feedback that, look, your medicine and surgery is okay, but honestly, your pediatrics needs a lot of work. It looks like you're significantly lacking in your pediatric information, and this is where you need to improve work. So I think the feedback is very important. And if the tutor is not able to provide you with that essential feedback, then what good is the value from any course? All right, and then we'll obviously couple it off with the 80 hours of CPD on completion, which will have a combination of online learning format via the portal, and obviously the live interactive classes as well. Now, before I jump on to the practice MCQs, I'll just stop share and I'll show you some of our resources. Or shall I? Okay, let's do the practice MCQs and I'll show the resources at the end. I don't want to waste time. So practice MCQs.
Okay, so it's time to go give you some taste of how AMC MCQs look like. Let me just share my screen. Is it visible now?
Yes.
Is it visible?
Yep.
Yes. Okay.
Okay, perfect. Now we have been speaking a lot. Would anyone of you would like to just read the MCQ? I'm not going to ask the answer. Any of the participants?
Come on, guys. We've got quite a few.
Yeah.
I
I will not be asking the answer. Okay.
Valeria should do it.
Oh, Rima has raised her hand. Rima, please unmute yourself.
Hi guys, Thank you for the session. So I read the MCQs. 79-year-old Dave is admitted to the intensive care unit for hospital-acquired pneumonia in context with COPD, exacerbation, and acute heart failure. Dave required intubation and mechanical ventilation. On his first night in the intensive care unit, his temperature is 99.7, 37.6. Blood pressure is 107/58 and pulse is 150, which is a sudden change from his previous vitals. Physical exam is notable for jugular venous distension and a rapid heart rate. Which of the following is the best next step in management for the most likely diagnosis? Chest radiograph, B, fast exam, needle thoracostomy, tube thoracostomy. Thank you.
Thank you. Okay, would anyone like to guess what's the diagnosis? We are not talking about the correct answer yet. It's okay, you can just blurt it out. We want to have a look at your video. Okay, I'll help you. So the physical examination shows that the JVP is raised, heart rate is rapid, and the patient is a bit hypotensive. It's Beck's triad. Something clicks. Sometimes it is for
stuff.
yeah. Okay. It's cardiac.
They're all shy. It's too much.
Okay. Yeah, it's cardiac tamponade. Okay, and why it has come so far. So the patient already has compromised lungs. Usually when we with our lungs, obviously the visceral pleura and the parietal pleura, and there is negative pressure present around them. With this mechanical ventilation, we have made some positive pressure around them. So we may have created a pneumothorax, and it's a tension pneumothorax. So what is the first best step for the tension pneumothorax? Okay, like it's the tension pneumothorax, which implies that there is accumulation of air between the lungs and the, let's just say, the other half of the in between the pleura. So it is the excessive air is stopping the lungs to contract, and also it is putting the heart at risk. Now my patient is at cardiac risk because he's developed cardiac tamponade and his respiration is also compromised too. I need to do something very immediately so that I could help my patient from developing these fatal complications, something that is very bedside. So what I'll do, I'll just go through my pocket, I'll take an alcohol swab and a needle, and I'll perform needle thoracostomy. So it will release the pressure and make the organs and make sufficient space for the organs to work aptly. This is going to make this tension pneumothorax into a simple pneumothorax. So what should be the answer now? Let's have a look. So this is the needle thoracostomy. We have done nothing, just like NG decompression. When the stomach is distended, I have decompressed using a needle. So I converted this tension pneumothorax into a simple pneumothorax. I still need to address the simple pneumothorax which the patient has gone through. Now the next slide. Okay, so there was COPD, mechanical ventilation, we induced positive pressure. Best next step, because the hemodynamic stability of the patient is at risk, so I have to save that. Now this is the explanation. Let me tell you, it was a recall. We have glorified it, so all the components are covered. So the patient is having tension pneumothorax. Now, based on the fact that there was a history of COPD, which means compromised, dilated, distended lungs, and he was mechanically ventilated, this hemodynamic compromise suggests a pattern of tension pneumothorax. What do I need to do? I just need to release that tension and just take a needle, prick it in the second ICS, and voila, needle thoracostomy, tension pneumothorax gone. Okay, why chest radiograph? So remember, on the way to investigations and management, a chest radiograph would be performed after the needle decompression and tube thoracostomy has already been done, because it needs intervention first. Next thing that was there is the fast examination, which is focused assessment of with sonography in trauma, something we have EFAST, extended fast. So if it is the best initial step in management of a suspected pericardial infusion causing tamponade in this patient with hypotension, tachycardia, JVP, and muffled heart sounds. So Beck's triad components are there. Patient has tension pneumothorax given there was history of COPD and mechanical ventilation. While it is true that fast examination could look for any of the pathologies, we need to immediately stabilize the patient with needle thoracostomy to help him. Thoracotomy, obviously, it is, as the names indicate, we are going to stab somebody in their thorax. So it is an aggressive procedure where the chest is opened and the pericardium is incised to relieve the tamponade. He does not need it at this time, so not needed. And tube thoracostomy, obviously, it would be performed after needle decompression in a tension pneumothorax, because this is how we play around with a simple pneumothorax depending upon its size and how it does manifest. So Laura has a clear picture of how it works around. Just to give you a gist how pneumothorax works. Now, if we have a look at this X-ray, forget about this is the X-ray, PA view, this and that. Focus, because we have just 40 minutes for one MCQ. What I can see, okay, the patient is compromised. Here on the left side, the vascular markings are very nice, but on this side, these are not, which implies that the lung has been collapsed and the black is always the air. So it has been collapsed and there is accumulation of air in the thorax, which leads to pneumothorax. Why is the patient is suffering? Because the patient is having a collapsed lung. So his respiration is at stake. With pneumothorax, it could come in any way. It could be spontaneous, but there are certain factors that may dispose you to develop a spontaneous pneumothorax. You are tall, thin, and white, and most commonly seen in athletic males and who have a positive history of smoking. Besides that, it is most commonly seen in ED following the patients who come from trauma. Other is the most basic etiology for most of the non-traumatic pneumothoraces is the fact that there is just this rupture of pleural blebs and bulla and blisters, and then it leads to accumulation of air. It could also be due to some underlying connective tissue disorders like Marfan syndrome. Now, how is it going to present and how we are going to pick it based upon our clinical knowledge? When the patient comes, he said, oh, I'm having shortness of breath. So he will be having difficulty and he will be trying to catch his breath in. He would complain that he may have sharp stabbing chest pain. Now the patient is having chest pain, he's having shortness of breath, and he's going to go into respiratory failure. So that you may find that the patient is fatigued because he was trying to catch his breath. The patient may look bluish or cyanotic. There would be rapid breathing and heart rate and a dry hacking cough as well. Now, at this point, we have to be very cautious that obviously we know that it's a tension pneumothorax, but looking at these facts, we'll never ever go with the tunnel region. Think of his COPD and any cardiac exacerbations as well. Okay, anything that says hyper resonant percussion, not in life, but for AMC, I would say, please think of pneumothorax, nothing else than that. And obviously the lungs are collapsed. You will get the air, but you will not get the breath sounds. So hyper resonance, but no breath sounds. Now, what my patient had this, he had an acute tension pneumothorax, which is a severe condition. When it occurs, air is trapped. Where it is trapped? In the pleural space, visceral and parietal. Why? Because usually there is negative pressure. But my patient, he had mechanical ventilation. So we, let's say, introduced some positive pressure, displacing the structures here and there and compromising his cardiac as well as pulmonary function. At this point, what should be the immediate management or intervention that should be done? Any needle, 16 to 12 gauges is fine, and just put it in second ICS, release the pressure, tension pneumothorax comes into a single one. Formal management, obviously we need to connect it to an intercostal steel drainage with a formal intercostal catheter, and that's it. Now, Dr. Laura is going to shed some light on the simple pneumothorax. So she has another MCQ for you to discuss. I'll just stop sharing my screen.
Thank you so much, Zainab.
Thanks, Laura. Up to you.
Do you guys think we should do the next one for like time wise? Is it all good? Dr. Rizwan, unmute yourself.
Yep. So I'll do. You can do the MCQ, I think, but what I'll do is that I'll just quickly show the participants who want to register for the course and how to go about doing that. So basically, just give me a second, please. All right. So can you see my screen? No. All right. Let me share my screen. I forgot to share the screen actually. Okay, share screen. Okay, so those who'd like to register for our, can you see the screen right now?
Yes.
Okay, okay. So those of you who'd like to register for the course, that is the MCQ course, which will be starting in November. They often ask me, where is this course? How can we register? How do we start? So I thought I'll just take them through. So the website name is emergencyfocus.net. That's written everywhere pretty much, you know, and you click on AMC courses. So once you click on AMC courses, that'll bring you to this profile. That's Laura, by the way, when you were doing
Yeah, with the 26 plus kilos there. Thank you
yeah.
for that picture.
And what you will do is you will come to the online MCQ course. Okay. And then you click on register now. When you click on register now, it will take you through this registration page, which will give you all the information. What's the fee? What's the number of days? We will have a timetable made out and put a link in the timetable here as well. But mostly there'll be 2 to 3 scenarios. You select, it is basically a fee $1,600, which is paid in 2 installments. You can select 2 and you can pay the whole fee upfront, or you can just select 1 installment and then check out. Now, obviously, if I check out, it will charge me. So I don't want to do that right now. But if you want to, that's the most simple thing to go about. Now, the other thing is that I just quickly show you the portal. So this is, can you see the portal? Hang on.
Let's see. We can't. I don't
You
think
can't?
so.
Okay, that's okay. Just give me a second. New share. You'll see the portal now. Can you see the portal now? Portal page.
Yes.
So once the course will start, these are all, this is our portal. So we've got all our cases here. We've got like AMC Clinical Bootcamp, we've got online clinical orientation, AMC Clinical Online Medical Career Guidance course, medical documentation, and this is the online MCQ course. So how to join the portal, you don't go into this website. It will be linked through the same website. So you'll only have to do the registration and payment once, and then you'll automatically get to make your account and everything like that. Once you go into the portal, obviously this is the faculty page, but it will have a welcome note, and then it will give you, before every session, it will give you a pre-reading. So right now you're doing respiratory topic. So it'll give you a pre-reading respiratory topic. So all of those notes and guidelines is specifically and chapter wise will be visible over here. Okay, that's just the notes for you to get ready with the portal. Then you'll have a live session. So live session will be a session with Laura or Zainab or Simra, in which you will do MCQs. Why right is right, why wrong is wrong. Why is it a tension pneumothorax which needs immediate natal decompression? Why is it not a cardiac tamponade? Why is why, and why is not why? So that will be doing and then you'll have a little quiz at the end, which will be uploaded. So all the MCQs that you do, it'll be uploaded here, and you can, have a look around and solve those MCQs. So that's one method of assessment. The other thing is you'll have all the sessions out here like this, session 2, different topic wise, and it'll all be topic based, like respiratory, GI, neurology, dermatology, then surgical topic, and emergency topics, pediatrics, whatever it is. And at the end, there'll be a trial exam, and you'll have a time to complete a trial exam with all the MCQs, and it will give you your results. And then the faculty will go on one-on-one session with you in that trial exam. So this is a very basic idea about how the portal and registration would work. Like, don't worry about the portal, which I'm showing you right now. Only thing you've got to remember is just that website where you register, and all of the other instructions would come in handy. Now, I think the participants would like to do some more MCQs with you guys. I'll excuse myself here, and you can finish up your MCQs. I think they're only you've got a few more, I think, Laura, isn't it?
One more.
All right. Okay. How about we do that? and and then we can finish off the session.
Okay, great.
All right, cool.
So let me share my screen. So let me, sorry, just gonna go down. Just have to make sure I don't go over. Give me 1 second. I just don't want to show the answer of mine. Okay, good. I have to stop it. Great. So I'm gonna read it myself just to cut some time. So we have a 25-year-old Harry that presents to the emergency department with sudden onset of shortness of breath, hacking cough, and right side paralytic pain. So we kind of know a little bit what this might be because Zainab told us before. His vitals are BP 135/90, heart rate 105, respiratory rate 25, saturating at 97% on room A. On chest auscultation, we can hear reduced breath sounds on his right hemithorax. On percussion, we have hyperresonance on the right hemithorax as well. And they did an X-ray already, and it showed 30% right side pneumothorax. No other abnormalities. Given this patient's scenario, what would be the most appropriate step in management? So in this case, we already got the diagnosis, right? So everyone knows this. We have that pneumothorax on a healthy patient. What do you guys think would be the management here? What would be the answer? So you've done already the X-ray. Anyone would like to answer? Let me see. Not sure if I have someone here saying A, chest tube insertion, chest tube insertion as well. Yeah, I would say chest tube insertion too, right? But that's why the AMC MCQ is so tricky. So the correct answer will be needle aspiration. Why? Well, because the AMC MCQ, it's a bit tricky and you need to know exactly what they are asking for and which specific guidelines they are testing you on, which is very important to know. So in this case, we need to focus on pneumothorax, and the AMC MCQ questions for pneumothorax, they have like a tricky and a specific way of approaching them. So we first have to know if this pneumothorax is primary or secondary spontaneous, or if it's traumatic, and that will change the management. In this case, we have a previously healthy young male that suddenly developed shortness of breath. In the X-ray, it only showed a pneumothorax. So in this case, we need to think that this patient has a primary spontaneous pneumothorax. So that's the first thing we have to identify with these questions. I'm gonna just make sure, of course, read what they're asking for, the most appropriate step, okay? So let's go through A, B, C, and D, and E, and then through a quick theory about this, which is very helpful for a lot of questions. So the most likely diagnosis here, as we know, is primary spontaneous pneumothorax. For you guys and me, I would have also answered a chest tube insertion. This will be the management of choice for traumatic pneumothorax, with for secondary pneumothorax that are spontaneous, but larger than 15%, or when a patient with pneumothorax is about to undergo mechanical ventilation or being transferred by air. So that is very important to remember because a lot of questions can come like that. B, which is our correct answer, is needle aspiration. The management options of choice for patients with symptomatic, because this patient had shortness of breath, primary spontaneous pneumothorax, or asymptomatic PSPs that are larger than 50% will require needle aspiration. Okay, so I'll explain the management in the next slide. So for C, mechanical ventilation, Zainab told us how this poor guy with a background of COPD developed this tension pneumothorax because he was on mechanical ventilation. So definitely this is not the correct answer. For observation, which could be also possible, will be considered for patients with primary spontaneous pneumothorax that are asymptomatic and have a small pneumothorax as well. So not in our case, because our patient is he's symptomatic and the pneumothorax is a bit bigger. Thoracotomy, not at all. Zainab explained really well what our thoracotomy is, and to be honest, it doesn't have really a role in the management of pneumothorax. Okay, so how to approach these questions and not get lost with all the pneumothorax theories and Harrison books and stuff. For this exam, MCQ questions, pneumothorax, you have to always think, which type of pneumothorax am I going to check now? So you have to think first, is it spontaneous or is it traumatic? Okay, there is no trauma history, so it's spontaneous. Is it primary or secondary? The way to know this is pretty much that secondary are all pneumothorax that will be secondary to a lung condition. So it will be all our cases that will give us asthma, cystic fibrosis, or COPD. If the patient develops spontaneously a pneumothorax with that background, it will be secondary all the time. So for primary pneumothorax, we have to follow this criteria to make sure it's primary. So no history of lung disease in our patient, no other chest X-ray findings that they are giving us that maybe this patient has tuberculosis and something in there, just the pneumothorax. A young patient, not an old one. It's not old, okay? It's not old, 50 years is young, but not older than 50. And not significant history of smoking as well. So this is very important for these questions, okay? So our patient was young. It did not have any other background of lung disease, and the X-ray only showed a pneumothorax. So, and it doesn't have any history of smoking. So definitely this is a primary spontaneous pneumothorax. Other problems with a lot of contour recalls about pneumothorax that you're gonna find is no one understands the size of the pneumothorax and how the Australians do it. Well, I went through the textbook of adult emergency medicine, which I said before, that was amazing. And here they tell you how the Australians follow the British Thoracic Society for the management of the pneumothorax. And they pretty much divide them into small and large, being small, those less than 2 centimeters, and large, those larger or bigger than 2 centimeters. But the problem is that the Australians and the British will always measure the interpleural space laterally, okay, at the level of the hilum. So they are giving us those 2 centimeters on this aspect laterally from the parietal pleura to the visceral pleura. But the Americans, and some guidelines are Americans, that's why you shouldn't follow them. They give us the answer with the cupula, so between the apex and the cupula. Okay, so the Americans consider a small pneumothorax anything less than 3 centimeters, but we don't care about this. Very important, 2 centimeters will more or less tell you that there is a 50% of collapse of the lung, okay? And we'll, of course, every time we do our MCQs and our theory, we'll give you all the MCQs that we find. So all the recalls created into MCQs that we find about the topics, we'll look through all our guidelines, subscriptions, and books, and we'll put them nicely all done for you. So it's gonna be very worth it, trust me. So management. So what are we gonna do? So your primary spontaneous pneumothorax can be managed in 3 different ways, well, 2 different ways. One of them is that you can discharge the patient and review in 24 hours. If the patient is asymptomatic, okay, no assurance of breath, the patient is just fine, asymptomatic or very, very little symptoms, and the pneumothorax is small. Okay, both of them have to be there to discharge the patient with observation later on with review, in 24 hours. Now, when do we consider needle aspiration, which is the case of this patient? When the patient is symptomatic, so needle aspiration, or if the pneumothorax is big, okay? In this case, bigger than 15%. So that is very, very important. I'm gonna go to the next slide. So we could do, after needle aspiration, we can do admission and then catheter drainage or chest tube or tube thoracostomy, which is another name for the same thing, as the next best step. If when we aspirate, the air that we extract is more or equal to 3 liters, and the distance, so, and then pretty much if the pneumothorax hasn't resolved and is still quite large, or if the patient has still significant shortness of breath. Okay, this is extracted from the British Thoracic Society, which is the same guidelines that the adults emergency textbook follows and Australia follows. And here we can see how exactly they have spontaneous pneumothorax. They are here asking if it's primary or secondary. So is the patient younger than 50, a smoking history or lung disease or anything else in the x-ray? In our case, it was no. So this is primary, as I explained before. Is it big or small? In this case, is less than, more than 2 centimeters, and or in this case, they gave us percentage, no centimeters, but they gave us breathlessness. So yes, our patient has shortness of breath, so we have to aspirate, okay? And just by following this and learning this diagram, you'll be able to answer all the questions of pneumothorax as well that you might get, okay? So that's pretty much it. That's an example of how we conduct our MCQs. That's it. Thank you.
Great. Good job.
Thank you. I think Dr. Rizwan is gone. Oh, no.
No.
Yeah,
you
I
could.
bore you. I bore you. Were you sleeping, Dr. Rizwan?
No, I was having a cup of tea. I thought it would be a good time. So,
Very good.
okay, guys, thank you very much for putting all that effort. One of the key points which I'd like to make in that with every clinical scenario, my approach used to be very simple. I am a hard-working person and I want to make sure that my hard work gets utilized in the right direction. So in this particular scenario, it says, what is your immediate management? And the hemodynamic compromise was there. So that makes my job easy in terms of diagnosis, that it is a tension pneumothorax, and any tension pneumothorax immediate management is needle thoracostomy. So that could be the other way around. So there are different ways of solving the same problem. Always have that kind of mindset. I know that I'm speaking from my experience, but then again, from the exam perspective as well, just make sure that simple approach is followed. One of the things which somebody told me when I was preparing for AMC1 and PLAB and even the fellowship exam is you read the MCQ stem without looking at the options and come up with the answer in your mind. And in that way, you have a 90% chance of scoring and hitting the correct answer, because then you're getting your mind to proactively search for an answer rather than being confused with the multiple options. So something for you to understand. Thank you very much. I'll thank you, Simra. Thank you, Laura. Thank you, Zainab, for putting up a beautiful session. And, we'll get, any questions. If anybody's got any questions, they can ask us before we close this sessions.
There is Mohammed Ahmed asking to leave the session on the page as well. So we are doing it right.
Yes, it's on the page. Yeah. And I'll upload it on our YouTube channel as well. I think doesn't matter if you're in here on the YouTube. And then it'll also be a part of the portal. So the AMC MCQ portal, this session, introductory session, will be there as well. Any other questions anybody's got? I think we pretty much covered all the bases. If you have got any other question, you can have a look at this. All right. Thank you, guys. Thank you very much. I'll end the recording and the session here, and enjoy the rest of your weekend. Unless
Thank you. Bye.
Thank you.
All right.
Thank you. That's so good.
Bye-bye.
Bye.
Bye.
See ya.
Bye.
Bye.